We'll be doing anatomy of the flexors and carpal tunnel. So when you're thinking about a carpal tunnel approach, you have to know the relevant pertinent anatomy within this region because there's actually a lot of very critical structures in a small area. In a standard carpal tunnel, we make about a 4 centimeter incision for an open carpal tunnel release within the palm, either distally at the end of the palm, at the end of the proximal palm, or proximally within the proximal palm. Our classic anatomic boundaries are Kaplan's oblique line, which is right at the ulnar corner of the thumb at the first web space coming down like this, and that's the distal end of your carpal tunnel. Also, you can feel the carpal tunnel, the transverse carpal ligament, when you're palpating within this region. You're in between the thenar and the hypothenar eminences. On the ulnar border, you can actually feel the pisiform right here at the base of the hypothenar musculature, and then the hook of the hamate about 1 centimeter distal and radial to that. So those are all good boundaries because your ulnar nerve is going to travel within guions, which is between those two bones, and your median nerve, which is within your carpal tunnel, is going to travel radial to the hook of the hamate. So those are classic boundaries that we use. Usually we make a 4 centimeter incision here, but for the purposes of the video today, we're going to extend this all the way up into the forearm to show the flexor tendons and some of the nerves within that region. So we'll make an incision. We'll extend this a little bit more just for visualizations in this cadaver. And I don't usually tee these incisions at all, but we will today. So as you're dissecting, first underneath the skin, you're going to see subcutaneous fat, which is this yellow stuff right here. And we'll go through that. I'm going to extend this down into this region just for ease of our exposure. So next, what you're going to see, you'll see these longitudinal fibers. Those are the palmar fascial fibers. So this is not the transverse carpal ligament. The transverse carpal ligament is, just as it's named, it's running from side to side. So we have to get through these fibers to get to the transverse carpal ligament. So we're just going to split them. So what you can see right here is you can see fat at the very distal end of these transverse fibers. So this is the end, the distal end of the transverse carpal ligament. And this fat is actually hiding your superficial palmar arch of vessels. So the median nerve and all the flexor tendons are all living underneath this transverse carpal ligament. And this is what we release when we do a carpal tunnel release. So, and you can see it's actually quite thick. There's lots of layers of these transverse fibers, and I'm not going to get into this distal area very much. And clinically, when you do this in the operating room, it's very, very satisfying to release because you can feel it spring open. So you can see I'm almost through all those fibers, but there's still one layer left. So I'm going to do that with my scissors. And usually in this operating room, this would take us about 10 minutes to do. It's not a long surgery. So now it's been released. And so if this was a real person, you'd see, as I pulled these tendons, you'd see the thumb flex down, because that's the flexor pollicis longus right here. Okay? So within the carpal tunnel, there's your 9 flexor tendons. So there's the FDSs to each of the index finger, middle finger, ring finger, and the small finger. There's a flexor digitorum profundus to the same finger, so that's 8 tendons, and then there's the FPL, and then there's also the median nerve. So you can imagine if you have a lot of swelling around these flexor tendons, the median nerve, which lives in this confined space where the bottom is bones and the top is this very tight ligamentous structure, if those tendons are getting swollen around the median nerve is going to get squished, and that's exactly what carpal tunnel is. That's why it starts off with numbness and tingling, and then it progresses to weakness. You see this structure right here, and this median nerve starts off in your brachial plexus and runs all the way down your arm. But this is the most common place for it to get compressed in a non-traumatic etiology. So that's your median nerve, and that's going to branch into the radial side of the thumb, the common to this web space, which splits to the ulnar side of the thumb, the radial side of the index, the common here, which splits into the ulnar side of the index and the radial side of the middle finger. And then the last branch, sensory-wise, is to the common here, which goes to the ulnar side of the middle finger and the radial side of the ring finger. And then there's also a muscular branch that goes to the one head of the flexor pollicis brevis, the ponens pollicis, and the abductor pollicis brevis, as well as the radial two lumbricals. So actually a very, very important nerve. And the ulnar nerve is just as important. It's one that isn't always given as much attention, but for everything we do in hand anatomy is very critical. So these are some of these other flexor tendons. So this is probably going to the middle finger. And it's the FDS, right? Because within the carpal tunnel, your FDSs are more superficial. It goes 3-4 over 2-5. So your middle finger and your ring finger FDSs are superficial compared to the FDSs to the small finger and index finger, which are deeper. And then your FDPs live on the same plane, just deep to that. And that's why in trauma situations, a lot of times we'll go proximal and distal to the level of the injury to areas where we know where the anatomy, where those tendons should live. And because you can imagine if somebody cuts their wrist right here and they cut all of their tendons, it's kind of a struggle because all the tendons look alike. It's a struggle to figure out which tendon goes to where. So we'll follow it distally and we'll follow it proximally to figure out what should connect to what.